Good afternoon. Welcome to the last session of In Conversation. And if I start stumbling, it's because it's been quite a long day. But we are going to talk about health inequalities, but just now we were having a chat about Pinot Noir from New Zealand. So you can see we've got, our life well balanced, actually. Really welcome. My name's Victoria MacDonald. I'm the Health and Social Care Editor for Channel 4 News and hosting this last session. And with me is Kevin Lavery, who is Chief Executive of NHS Lancashire and South Cumbria ICB, and Dr. Annie Williamson, who is an NHS doctor and research fellow at IPPR. And just starting off, Kevin, for instance, you have extensive experience working with deprived communities and regeneration initiatives and extensively with the health sector. And actually, we were just talking before about how you do your own State of the Nation report. So I'm going to ask you, what is the state of the nation as such at the moment?
Look, I think it's very challenging is probably the right way to put it. I think in my report, which I published last year, I said it feels like we're on the edge of the cliff, and if we're not careful, we could fall off. So I think, health inequalities really challenging. Blackpool probably has one of the worst life expectancy age ranges in England. For men it's 69 and for women it's 74. The English average is just under 80 for men and just over 83 for women. But on the other side, Windermere is one of the best with I think it's 83 for men and 88 for women. So we've got some real pockets of deprivation. We've got 33 what are called priority wards, where you've got severe deprivation, which is a lot, something like 13 or 14 in Blackburn. But you've also got pockets of affluence and really strong health outcomes, so it's a mixture.
Well, I think you see that across the country, that repeated, and we were talking earlier too, the tram line or the central line, where you get on at one end and get off at the other end, and you're going to live 20 years less than at the other end. Annie, let me introduce you more fully, a research fellow at the Institute for Public Policy Research. We work on the Commission on Health and Prosperity, and actually I've done a piece for Channel 4 News on it. It's very interesting, some of the work that's coming out of there. You're also a doctor in the NHS focusing on infectious disease and health inequalities across South London, which again has huge pockets of inequalities and deprivation. What do you think? How do you think the state of the nation is? I mean, I know we all know this, but it's interesting to get your take on it.
Yeah, thanks, Victoria. I think what stands out to me, both in my clinical role on the wards and in the community, but also at a bigger picture in my research space, is not just that we're constantly feeling under pressure, on the verge of crisis, but that we're stuck here. So every winter we're facing winter crises. Every year we're talking about people departing the NHS. We're talking about health inequalities that are present and when failing to turn the tide. So I think the really interesting question is, despite this focus on widening gaps, on underserved areas, on measles vaccines not getting delivered across South London, for instance, despite all the best efforts to fight that, there's underlying challenges that are standing in the way. And at the top of my mind there, we're failing to get the best out of the workforce. We're failing really to draw people in from the communities most affected to really co-design programs, for instance, for vaccines that work with people rather than doing onto them. And we're seeing the results. We're aspiring for change, but in practice, it feels like we're firefighting all the time.
You're right, we keep hearing all these same things. So is it about persistence is the word I was looking for, I guess, but Is there something that could give us some hope that we are not going to keep having this conversation, that we won't be back here next year? And I'm not even just talking about the fact that we're going to have a new government of, whichever persuasion.
I think so. Despite that sort of slightly despondent starting point of cycles of inequality and challenge, I'm fundamentally optimistic. I work in the NHS because I love to work with patients and I love what it aspires to. And it does feel that we're on the cusp of something different. First and foremost, I'm optimistic about the idea of mission-focused health, whether that's at the national level and the promises of kind of government parties, but probably more fundamentally, at the NHS level, I think we're clearer now that striving for healthy outcomes, narrowing the health inequalities gap, improving life expectancy in the areas that need it most, requires people to pull together from within the NHS, but also across the ICPs, across the voluntary sector. So if we get that right, if we galvanise people and start pulling together, I think there is hope to turn this despondency into an optimistic, self-perpetuating cycle. The staff in the system want to serve patients, but you need to feel that everyone's pulling together, that we're starting to get momentum, and then that will gain its own steam.
I mean, I suppose we could leave aside for now the fact that the system probably or does need more money. And I think that there is a lot of agreement, even if it's not being discussed, for instance, in this election campaign. But we were talking earlier, Kevin, not so much about the why, but about the how. How do you deal with it?
I think that's the...
Actually, I could ask you why you'd take on this job. Rather than...
I think that's the big challenge. It's how do you... Everyone would agree there's sort of 14 years difference between the most challenged community and the most affluent community is not acceptable in a first world country. But how do you actually address those inequalities is the challenge. And there are some brilliant schemes. I mean, I went to a project in Morecambe. It's a troubled coastal community. It's a project called The Well, and they work with people, young people who are drug addicts. There are no doctors or nurses involved. It's all people with lived experience who've been through that before. They now work with a range of GP practices in the area to get people into the well who've got those sorts of challenges, and they work miracles. So that's an example of the sort of thing that can actually work, and there are plenty of those around. It's how do you scale them up? But I think one of the key things is to work through various niche groups, disability groups. In our case, we've got a very big Muslim community in East Pennines. Use the mosques, use those networks rather than try and do it all the NHS way. Use their networks, and that's how you get to people that actually the NHS doesn't always get to.
Yeah, Kevin, just to jump in on that, because I think you're absolutely right. There are real pockets of excellence across the NHS. Fantastic initiatives, say, on drug and alcohol support or mental health support for young people. You hear of these wonderful stories. But what we're surprisingly bad at, I think, for a National Health Service is sharing that excellence. So we come here, we talk about best practice, it gets written up, and then it dissipates. And I spent 4 months in the US on a fellowship working there. They are much better at collecting data, national or city level dashboards, and then dispersing the best practice in a way that still tailors it to the next setting. So I think that's a challenge for the next 5 years, to go from sort of spotlighting pilots to really using that evidence to share what works.
Actually, that came out very strongly in our last session on vaccinations, as sometimes the data was lagging so far behind that you would be reacting to something that had happened 15 months ago. This must be a problem for you.
Yeah, I mean, we've got people say we haven't got enough data. I think we've got too much. It's actually what we need is more insight. It's picking the key things and acting on it is probably the power of that. And there's, it feels as a chief executive you've been bombarded from every direction with data. and it's actually insight you need, and then you've got to follow that with action. So I think this is the sort of area that cries out for, absolutely there are major resource constraints. Pick a few things, do them really well, and then build the confidence to do more further down the track.
I mean, one of the things that we have heard, for instance, so far during this election campaign is the word reform, which I know sends a shudder down everybody's spine. But how do you feel the ICSs and the ICBs can prove themselves enough to keep the structure that we have now? Do you think you're safe? Because you're not going to deal with this health inequalities or the issues if you're not feeling safe in your structure.
I think if you look at the sort of challenges, we've got major financial challenges in our area. I mean, according to the HSJ, it's of the order of £400 to £500 million a year as our underlying deficit. We've got the inequalities we've just talked about, but at the same time, we've got huge opportunities. If you had a blank sheet of paper, would you have 8 hospitals with 8 elective care centres? Would you have 6 A&E centres? Would you have 5 separate sets of support services? So there's a lot of opportunity to release resources and put them into the front line. And I think, are the ICB safe? I don't know. It's not my call. But a lot of the problems we face are system problems and can't be dealt with at the level of the individual trust. They have to be managed across the system. So we've got to get on and deal with that and do something and show that it's worth it.
I wanted to ask you to, Annie, sort of off the back of this, about devolution. I know we're here in Manchester and there are some good examples of what's happening here. How do you think this shift to integrated health is going to help?
I think there's real potential, and we're falling short of that potential so far. What do we need for devolution to work at its best? And Greater Manchester is one of the best examples so far. Where it really offers promise is collaboration outside of the existing ICS patch. So Greater Manchester stands out to me because they're linking to housing policy, they're linking to employment policy and the NHS as a health promoting employer rather than one that drags staff down. So where you can get that right, where you have the ICS and the ICP linking to the metro mayors, there's huge potential. But what are we missing? Well, right now, I think the ambition isn't quite there because we don't have as much support for the ICSs as I'd like to see. So that's not to say there's not great work being done. Clearly there are really excellent people. But you could build up the investment in leadership across the board, so all ICSs match the best. And then really you could have much more locally set goals. I've done some recent work thinking about shifting away from centrally set targets for ICSs over sort of across the board, and instead having the centre with a clear health mission collaborating with ICSs. So they rolled this out in Victoria in Australia, where each health board, similar to an ICS, sets their own small number of priorities. In East London, that might be serious targets on tuberculosis action. In the north of England, it will be a different set of priorities. So if you have that sort of ambition, the support to deliver, investment in leadership and accountability, that there are those results for the local population, that's where I would see ICSs singing at their best. And Greater Manchester might show where we'd hope to go. I think there are other, fantastic examples. West Midland's really promising too. My concern would be the pockets that are falling behind. We have to make sure we're not leaving in the dust, because an ICS shift that widens health inequalities would be the worst of all worlds.
It is worth noting, Victoria, that Manchester has actually a really important role historically in inequalities and how to solve them. Probably the biggest jump in health outcomes happened in 1848, not 1948, when the Public Health Act was first passed. That was based on the Chadwick report. He was a Mancunian, and he told the story of the terrible inequalities that were in this city. And Manchester became the first city corporation to have a water department with clean drinking water and with a proper sewerage system, the first in the world. That was a transformative change, and it shows how system thinking can really make a difference to health, and we just need to do more of that.
Is it an inflexible system? So is this what you're saying? And are you saying that that you can work within the system? So I'm not quite sure whether you're in agreement or not.
I think there's a lot of agreement. My thought is that ICSs can go much further. Honestly, when I'm in my policy role, I think about ICSs all the time. When I'm on the wards in the hospital, they feel currently too far removed from what I'm thinking about most and what my patients are thinking about most. So the 16-year-old that I saw last week who was in A&E essentially because of damp in their housing, that is on the top of my mind, and I'm sure there are people in the South East London ICS that think about that deeply, but it was not the front page of their website, and it's not the thing we're getting emails about from them. I think that sort of shift to patient-led priorities, clinician-led priorities would make the ICS feel a lot more proximate, and then you start to galvanise people to work with that being the primary institution for change rather than another layer of bureaucracy.
But that is that not about flexibility, or about, is it too structured at the moment that they don't have the flexibility to say, actually, we're going to make this our priority?
Yeah, I think you could have more autonomy, but with that expectation to deliver on those set goals. And that's not totally handing over all vision to ICSs, but collaborating, designing what matters best, and then an expectation to actually provide that.
Do you think, Kevin, when you hear what Annie's saying there, she's talking about, when she's on the ward, she thinks the ICS feels a very long way away. Yep. When you're in the ICS, does the Trust Hospital seem a long way away from you?
Look, I think we were born in the wake of the pandemic. We've got massive financial constraints. It would be nice not to be in that situation. I think we'd have a lot more flexibility if our finances were stable, and we could do more. We could invest in a lot of the prevention things. We could work with local government on the underlying determinants of health, most of which lie outside of the GP practice, outside of the hospital. But we are where we are. There are lots of opportunities. We are constrained, but we still see lots of opportunities, and there are lots of fantastic schemes that could be scaled up. So I think, yes, we are constrained, but we have to be optimistic and build up and scale up on the good things.
Do you think there's been enough discussion so far, and I know we're only halfway through the election, but do you think there's been enough discussion about prevention?
Yeah, I think there's a lot of headline and not a lot of detail. And this is the story of prevention at the political level for decades. If you go right back to 1948, prevention is in there, and yet we have built a sickness service rather than a health service. And that's what we continue to see and continue to invest in. For all the talk about a shift to community and primary care, the acute sector has more as a proportion of the resource than ever. It's like if you go to your garden and plant a huge mint bush and it sucks up all the water from the other trees. And look, I work in an acute hospital. There's a huge importance for those services, but I would rather people not come in the door of A&E with a broken hip because we actually built the physio to prevent them falling at home, or put in place the railings to support someone to live healthily in their later life. So I think there's a lot of well-intentioned top-level commitment to prevention, but when it comes down to it, it's micro-level policies. It's investing in district nurses, investing in community sexual health, building up Sure Start or youth clubs as well, things outside of health with meaningful, coordinated effort that goes beyond lip service. And that's where I think we struggle. It's very easy to say prevention and quite hard to measure whether we're working towards that goal. I empathise. It takes 5 or 10 years for prevention investment to pay off. But we have to be ambitious, and we have to hold the leaders' feet to the fire on this, or we just won't see this system turn around.
You're nodding.
Yeah, look, I think it's right. You know, most of the spend does go on the sickness, and it is absolutely the right thing to do. And again, there are a lot of hopeful signs. You know, an example in our area would be there's been a big push around hypertension across the whole of Lancashire and South Cumbria, and we've got something like 20,000 more people doing their readings. That has a tangible difference. So it's building on those things. But again, we're in a very challenging time where, you know, the money's not freely flowing, and it is difficult then to manoeuvre. But I think you're right. We need to keep up the good fight. And if we can stabilise our finances, these are the sorts of things we need to be really prioritising.
Oh, I'm very happy to take questions if anybody here has anything that they would like to ask either of the panelists. We have a microphone. It's one question here and then another one here.
My question is to
You
Kevin.
say who you are and where you're from.
Sorry. My name is Anjem Shazad. I also work for Lancashire South Cumbria, ICB. So just going back to the question to Kevin, please, if you can answer. You mentioned there's a lot of plans probably in the pipeline with regards to engage with the local communities. You mentioned including Muslim community. If I speak with any member of the community in my area, nobody knows anything about ICB, yet alone any plans.
Yeah.
How do you foresee engaging more with the local communities? I know you gave them some examples. And given the financial challenges we're in at the moment, how do you see those plans being prioritized? I guess there is a lot of work needs to be done around the engagement and communication.
Yeah.
I'm right.
So I'm not too worried that they don't know who the ICB is. They usually know who the NHS is and the local council. And I think it's not about promoting the brand of the ICB. It's more around promoting the points of access there. So I'm not too worried about that. I don't want to be marketing the ICB's brand, but I care about the local authority and the NHS. So I think we've got to work through those networks, and we're in recovery and transformation in our area, and there are lots of things we can do to address inequalities that directly benefit all of that. So a perfect example would be the most disadvantaged wards are the areas where we get the highest number of people presenting at A&E. So we need to work with integrated teams through the primary care networks in those communities. That's the sort of thing we are prioritising. That makes a difference, and I think your local communities will know those people, and you know, we're supporting them, powering them, if you like, behind the scenes, and I think that's the right way to do it. So work with the local agencies of health that you know on the ground, and the ICB will provide some resource and support for that, and that's the way forward.
Can I just add there, though? I wonder if we can go further in building local democracy into the ICS system. So the places that devolution has worked best, you mentioned Manchester, West Midlands, is where we have the ICS sort of coterminous with the local authority. So in Manchester, there's an elected mayor who is directly linked to the ICS and to the health vision. We have Oliver Coppard as the leader of the local ICS in his area. That's where you have people voting on issues of health, not just the NHS, but issues that matter to them every day, and where they feel connected to the ICS. So maybe they don't need to know the name of each level of the system, but they should be engaged in whether the health service is working for them inside and outside the inside and outside the NHS. And we can strive for that across the board, because the pockets where it's working really well.
Thank you.
What do you think? Do you think that it needs better education, better communication, better education of the public?
Yeah, I think better engagement in terms of the communication and education, definitely, that will go a long way. Yeah, thank you.
Another question here, and then one down here.
Hi, I'm Matt James. I'm with Reset Health, which is a clinical services provider delivered digitally in obesity, which is treatment and consequently preventative of a whole range of other conditions. Clearly what's going to make our company work well is investment into prevention in healthcare, but I'm going to ask a question that sort of tends in a completely different direction, because Kevin, you spoke about the Public Health Act 1848. Annie, you've talked about mould in somebody's house, and some of the other factors, like the mint bush example, I think was really nice. But at a political level, given that Labour are launching their manifesto in Manchester today, and all of the political parties are bound by the reality of politics to compete about the amount of money they're pouring into the NHS, what could we do from within the NHS to give permission to the wider system to actually start to behave again and address those wider societal issues, so that we can put more money into housing, we can put more money into public health, we can put more money into those other things which actually might take some pressure off the NHS?
I think the first question is how we set the goalposts, what those goals are and who sets them. So what I liked in Labor's manifesto is the mission framing leaves space for a real focus on healthy life expectancy. One of their goals is narrowing or halving the life expectancy gap between the poorest and richest. And that does open up space to continue to fight and to keep the pressure on for investment outside of the sort of headline NHS battlegrounds. That's my first thought. But the other is to look at where the NHS interfaces best. So primary care is a great example of this. If we take the sort of momentum or the focus on rebuilding primary care and make the case that the way to have great primary care is not just that you can get through by phone when you call, but when you get to that appointment, they'll have resources to sort out the damp in your home because they can direct you on to the right preventative services. And that means the GP has time to spend giving continuity of care with the person with hypertension. That sort of rethink with the real policy detail, the evidence of what's worked in primary care, say, lets us sort of seize the metal here, pick up on what's already at the top of the agenda, because I don't think we can totally change what people on the doorstep a long way from here care about most, which is going to be A&E and GP and elective waits, at least for the time being. But we can make the true, powerful case that the way to change on those issues is also to get these wider system determinants right at the same time. It can't just be firefighting, or we're going to be back here in a year's time, in 5 years, in 10 years.
I think one of the challenges here is it's not actually all about the NHS, it's about the underlying determinants of health, and most of that lies outside of the NHS. Quite a lot of it lies within local government. If you're in Liverpool and you're the local authority, you get about 60% of your income through government grant. If you're in Surrey, it's probably about 5%. So if you have an austerity program and you get your government grant cut by 30 or 40%, it has a disproportionate effect on local authorities in the north and the Midlands. And all of those services around social housing, recreation, sport, get disproportionately cut. And I think we've seen the impact on it. We've had a 15% increase in A&E in the last few years, people presenting. I think that's partly related to a really significant cut in local government services that are about the wider determinants of health. And it's interesting, the dampness in houses, there was a Rochdale Housing is nearby. That was the national case that led to a change in the law right here in the Greater Manchester area. So I think it's a perfect example of that.
We had a question down here. Sorry, I was looking for that.
Hi, my name's Imran Chowdhury. I'm a Director of Public Health in Sutton in southwest London. So really enjoyed your talks, and lots of things I kind of recognised and empathised with. I think one of the really difficult things, certainly in my system, is, if I'm really honest, the lack of enough honest conversations. And there's always a formula in a very complex system to just turn the arm over, write another strategy, at whichever level of the system. That can tick the box sometimes and provides a smokescreen, I think, sometimes for some of those difficult conversations. And I think you've alluded to that, haven't you, in terms of, variation in performance in terms of dealing with long-term conditions between GP practices or primary care networks. How do we get into that nitty-gritty conversation, or differences in local authority performance in facilitating growth of their community assets and creating more health creation on the ground, or indeed between trusts in terms of how they deal with waiting lists. So I just wanted to reflect back to you, and I know this is a slightly difficult question, but how can, within ICSs, how can we begin to, let those honest conversations emerge?
Really good challenge. Look, I completely get what you're saying. We had 8 CCGs in Lancashire and South Cumbria. We had 8 different levels of service around the place. And the acid test of whether we're making a difference is, are we being open and transparent about that? So one area is the local funding of GPs, for example. It varies massively from one part to another. So we will be starting to equalise that over a period of time, starting next year. These are difficult things to do, aren't they? But that's why we exist. If we're not making the difficult decisions, then why bother if you keep things all the same? So I think you're right. This is challenging territory. You don't get a gain without some pain. So I think your point is absolutely spot on.
Yeah, I echo that. I think it's a really good challenge. My challenge in response is you get honest conversations if you listen with willingness to change. And I'm answering that really with my frontline hat on. I can tell stories of the challenges that we face each day that the workforce know about or patients know about. So yesterday we struggled to discharge a patient essentially because blood tests took 2 hours longer than expected. We needed to print a paper form to send someone home with for their discharge letter, and I was trying 6 different printers to get one that could actually get the paper to come out to send this person on their way. This person staying in hospital overnight is bad for the system, bad for the patient, frustrates the workforce. But if I sort of shout this into the void and don't get heard, then those conversations dry up. So what do we need? It's not just let's have an honest conversation, but designing a framework to unlock those insights and act on them. If that listening ear is really there and goes to the right level. So for my story, it's probably to the clinical leadership level, but there'll be a different sort of conversation about whether we invest in hypertension or vaccines or diabetes as top priority at the ICS level. There you also want staff insight and patient and public insight going to the correct level there. If we start unlocking those ideas, that's where the conversation goes both ways, not just from the top down, but back out, extracting the best, unlocking the potential of our system. That's what makes me really optimistic, Victoria, but we have to design the system to get there.
Yeah. Did that answer your question? It did. Yeah, good. I mean, transparency, of course, is a critical element of it, but one thing that has come through clearly in many of the sessions is about involving the community, about not being patronising anymore. That absolutely has to stop, because the community knows what questions it wants to ask. It wants to know what is going to be done with them as well as for them. And I think the conversation is overdue. People keep talking about having it, but somehow it doesn't always seem to happen. On that note, I'm sorry I've run over again. I've got very slack over these last 2 sessions, but it's all too interesting, and I keep wanting to go. But I'm sorry to have to bring it to a close. Can I just thank you, Kevin and Annie, for your insights, and thank you for your questions, and could you thank my panel as well?